right, I think we have a good number of people to go ahead and start the morning. Good morning, everyone. Welcome to our February AIDS Clinical Conference. I am delighted to present our speakers today. We have two fabulous women here who are leaders in their field, and we're really fortunate to have them speak about something that they're experts in. So I'll start with Dr. Shapiro, who's going to be going first. Many of you know her. She's an assistant professor in the Department of Global Health, as well as in Department of Medicine, Allergy and Infectious Diseases. And she's a physician scientist, really passionate about TB research, both locally and globally. And that has been her passion all along, focusing on prevention and treatment, specifically in people with HIV. And then more recently, you probably have seen her name in a number of papers related to COVID-19 infection, where she's led some pivotal trials and treatment for COVID-19. And then secondly, Dr. Lara Strick, she's a clinical associate professor, and I've had the pleasure and honor of being her colleague for many years, starting an internship back in 1999, and she trained here in infectious diseases as well. And she has been really a champion for the care of incarcerated persons, specifically focusing on prevention and treatment of infections. And she is our expert today because she was instrumental in the response to a TB outbreak in our prison system in Washington State. So welcome our two speakers. Thank you.
Thank you so much, Sharisha. I'm going to go ahead and get started with my slides. So we're going to tag team, and I will speak first about prevention of TB in people living with HIV. And then we'll turn it over to Dr. Strick for TB treatment updates. And then we'll take questions all at the end. But I'm happy to have Sharisha monitor the chat for any questions that come throughout. But let's plan on questions at the end. So here's our disclaimer. I have disclosures from VIR related to COVID treatment. And just a warning coming up, there are going to be a lot of acronyms that I'm going to use. I'm going to try really hard to define them when I use them, but this slide is to be a reference point. And I just want to highlight that I'll be talking in sort of equivalently using the terms latent TB infection and TB infection. And we now recognize that TB is a spectrum of infection ranging from initial infection to incipient disease to subclinical disease to active disease. And as our understanding of the pathophysiology of TB changes, some of the terminology may be a little slower to change. So you'll hear me say both TB infection and latent TB infection, and that is distinct from disease causing illness that is transmissible, which is what Lara will be talking about. So why are we talking about TB prevention for people living with HIV? Well, still in this age, TB is the leading cause of death for people living with HIV worldwide. And there is excellent evidence that providing TB preventive therapy for people living with HIV reduces TB incidence, reduces TB mortality, and reduces overall mortality in excess of the benefits of providing ART alone, as shown in a study by our colleague Jen Ross in an analysis of multiple studies of providing isoniazid preventive therapy to people living with HIV in global settings. There has been in the last 2-3 years, new evidence in advances in TB preventive therapy and new guidelines. So today is really a chance to talk about some of these updates in the screening and treatment of TB infection, and provide some guidelines for how to make choices about what regimens to choose. So in a global setting, the WHO has recently updated their guidelines for TB prevention. And in the 2021 WHO guidelines, the recommendation is to screen all people with HIV for active TB disease. And in high TB burden settings, if active TB disease is excluded, then everyone with HIV should be presumptively treated for TB infection once TB disease has been excluded. And the regimens that tend to be used globally are primarily 6 months of isoniazid, or 6H, but increasingly 3 months of isoniazid and rifapentine. And the reason I bring this up for our context, a more of a US-based context, is that it's as countries are scaling up their TB prevention programs within their HIV programs, it's important to be cognizant that patients coming to US-based healthcare systems who may have initiated ART overseas may have actually received a course of TPT already. And so when doing screening for TB infection, it's important to check in with patients about what TB preventive therapy have they received in the past, and have they had any subsequent exposures that might put them at risk again. So in US settings, in US clinical settings, it is also recommended to screen all people with HIV for TB infection. The screening should take place at entry to care, so at the time of HIV diagnosis or ART initiation. And it is recommended to do repeat screening under certain circumstances. So there's no need to provide annual TB infection screening, but if at initial screening, the CD4 count is less than 200, there's a very high risk of false negative latent TB test results. And so it's recommended to rescreen patients after they've been on ART and reconstituted a CD4 count. Similarly, if people have a negative screen at baseline when they come in, and then subsequently have a new exposure to someone with active TB, then there should be another screen done at that time. And what do we mean by screening for TB infection? There are two general modalities of screening for TB infection. The preferred modality for people living with HIV is an interferon gamma release assay, a blood test that tests for basically an immune recognition of TB. And the tests available in this country are the quantiferon and the T-spot. In our setting in Seattle, the quantiferon is the most commonly used test. And the interferon gamma release assays are preferred for people living with HIV to the PPD or the skin test, both because of increased sensitivity and specificity for TB infection, and administratively, it's often easier to get a one-time blood test than it is to administer a skin test and have someone come back for reading for a skin test. The other advantage of IGRAs is that they end up in the medical record, in the labs. It's easy to follow. PPDs are not as straightforward. So people coming in preferably should get an interferon gamma release assay test. If a screening test is positive for latent TB, then the patient should get a chest X-ray to exclude active TB, along with assessment for any symptoms to make sure that you're not dealing with TB disease. And particularly when considering people living with HIV coming from TB endemic settings, not only is IGRA preferred for its increased sensitivity and specificity in general, but for people coming from TB endemic settings where the BCG vaccine is routinely given to infants, the IGRAs are preferred because there's no cross reaction with BCG, which can happen with the PPD or TST result. And another important consideration for people coming from TB endemic settings, positive quantiferon can be a marker of a prior course of TB disease that has been treated. And so it's important to confirm with patients if they've had previous TB, if it's been treated, to interpret the LTBI test to see whether this person does in fact need latent TB treatment, or if what they have represents a previously treated episode of TB. So we have increasing numbers of options for latent TB treatment, which is great. It's always great to have options. It can be kind of confusing. And the guidelines have changed for what is preferred recently. So broadly speaking, the latent TB treatment regimens can be divided into shorter course regimens, which contain rifampin or rifapentine, and the longer isoniazid only regimens. Because the rifampin containing regimens are shorter, treatment completion tends to be better, and those are now the preferred regimens. So the main ones that we consider are 3HR, 3 months of daily isoniazid and rifampin, 3HP, which is 3 months of weekly isoniazid and rifapentine, 4R, which is 4 months of daily rifampin, and then the 2 isoniazid regimens, 9H and 6H, both of which are daily isoniazid. Excuse me. So a few notes about these different regimens. So the rifamycin containing regimens are preferred if possible. I'm trying to keep rifampin and rifapentine in orange to remind everyone that this has the side effect of turning secretions orange, and that's how we'll visually identify it here. Again, better treatment completion rates for the rifamycin containing regimens, but rifampin and rifapentine have significant drug-drug interactions with other drugs that patients might be taking. And particularly important ones to consider are warfarin, hormonal contraceptives, anti-epileptic drugs, steroids, opioids, and of course, antiretrovirals. With the isoniazid-only treatment regimens, the data shows that the 9 months regimen has higher treatment success, meaning a smaller proportion of people will develop active TB at 2 years after their treatment. But the 6-month regimen has a lower risk of hepatotoxicity, which is cumulative over the course of treatment. So as of 2020, the 6-month regimen is now preferred over the 9-month regimen. The incremental improvement in TB outcomes with 9 months is outweighed by the hepatotoxicity that's experienced. So what we have now for guidelines, the DHS guidelines for opportunistic infections in people living with HIV recommend as a preferred regimen. They still recommend the 9 months of isoniazid because that's where most of the data lies. But a recent panel update allows 6 months of isoniazid as a single drug regimen, and as an alternate regimen, 3HP, the weekly 3 months of isoniazid and rifapentine. And certainly both the longer course and the additional hepatotoxicity may often make 6 months preferable for an individual patient than the 9 months. But currently the guidelines do still prefer 9 months. The panel update also, sorry, my slides are hidden by my screen, by an aspect of the screen, and I can't quite see this. So this is just reiterating the ART interactions with TB preventive therapy, and highlights some of the interactions that need to be taken into consideration with first line ART. So we'll go through that in a little bit more detail. So because rifampin and rifapentine are CYP450 inducers, there are interactions with many antiretrovirals. And because of this, it's really important to do shared decision-making with patients to determine whether switching ART to optimize TB preventive therapy options is preferred, or choosing a TB preventive therapy option to match a preferred ART option is the priority. So there is what I like to call the universal TB preventive therapy. The daily isoniazid regimens can be used. They're compatible with all ART. No ART adjustments need to be made. And then conversely, a tripla is sort of the universal ART, the ART regimen that's compatible with all LTBI and TB treatment regimens. All other LTBI and TB treatment combinations are likely to require some ART adjustments. So going through some of these interactions and compatibilities with key ARVs, importantly thinking about bictegravir. So a lot of patients are on Biktarvy. Bictegravir has been shown to be contraindicated with rifampin or rifapentine. So there are no rifamycin containing LTBI regimens that can be used with Biktarvy. The rifampin lowers the concentration of bictegravir below therapeutic thresholds. Dolutegravir is okay with all regimens, with the caveat that if rifapentine or rifampin is given daily for LTBI treatment, the dose of dolutegravir needs to increase from once daily to twice daily, and that should be extended until 2 weeks after the end of the rifapentine therapy. So it can be used, but requires some adjustments. Raltegravir is okay with weekly rifapentine, no adjustment necessary, but it is inferior to efavirenz when given with a daily rifapentine regimen. So boosters are generally a contraindication to rifapentine or rifampin. Kobe cannot be given with rifampin, and TAF is not preferred. There are PK concerns. However, TDF, tenofovir, is fine to be given with rifampin and rifapentine. With PIs, RIF interacts and is contraindicated with most PIs. Boosted lopinavir can be given, but the dose needs to be, again, doubled to BID, and that double dose needs to be continued to 2 weeks till the end of rifampin. I had planned to go through some of the ART alphabet soup, but this is really just a reminder of first-line ART, which will then present in contrast with the TB preventive therapy regimens to kind of show what combinations are okay and what require some adjustments. So reminding that first-line ART is either an INSTI and 2 NRTIs. Biktarvy is first line, but that is contraindicated with rifampin LTBI treatment. Dolutegravir, so Triumec or dolutegravir plus TAF or TDF are first line, remembering that Descovy with TAF FTC can't be given with RIF and rifapentine, and then dolutegravir 3TC is another first line regimen. Alternate regimens have varying compatibilities. I'm not going to go through them one by one, but really Atripla is the only fully compatible. So this is my cheat sheet for thinking about combinations of TB preventive therapy and ART. So 3HR, so this is the daily 3-month isoniazid and rifampin, can be given with Atripla. So we see Atripla is compatible with everything. It's our universal ART. But TDF FTC and BID dolutegravir can be given safely with 3HR. And this is really FTC or 3TC. So a lot of folks internationally who are treated with dolutegravir, lamivudine, and TDF can get 3HR daily with the dolutegravir dosed twice daily. 3HP is preferred as a rifapentine containing TPT regimen because as a weekly dosed medication, there is no dose adjustment needed to dolutegravir containing ART. So TDF, FTC, dolutegravir, or Atripla are both fully compatible with 3HP. And as long as TDF and not TAF is given, this is a great no interactions, no combinations. And the distinction between, again, 3HP and 3HR is that 3HR is daily. So with daily, you do need to double the dolutegravir. With weekly rifamycins, you don't need to double the dolutegravir. That can be unchanged. Again, 4 months daily rifampin. Again, doubling dolutegravir with TDF FTC or Atripla, and the 2 isoniazid regimens, no change is needed to any ART. Those can be given with any regimen. There is an alternative regimen recommended in the DHHS guidelines and also recommended as an alternative regimen in WHO guidelines. This is 1HP, which is daily isoniazid and rifapentine for 1 month. The studies that were done with 1HP showed that it was non-inferior to 9 months of isoniazid in people with HIV taking efavirenz-based ART, so Atripla. There have not yet been studies with dolutegravir or INSTI-based ART. There are some studies ongoing. It is likely that if it is given with daily with dolutegravir, that the dolutegravir will need to be dosed daily, but that study is currently ongoing. We should have an answer to that, I think, by the end of this year. There have been studies showing that 1 HP, so a 1 month TB preventive therapy regimen, given with TDF, FTC, dolutegravir with double dose dolutegravir remains therapeutic at the levels of dolutegravir. And depending on what the next round of PK studies show, the dolutegravir may not need to be dose adjusted with this regimen, which would be great because we'd have 1 month of TB preventive therapy and not need to adjust first-line dolutegravir. So when thinking about what are you going to do for your patients, once you've identified TB infection that should be treated, important to remember that switching ART is a very vulnerable time for loss of virologic control. So if you are making a switch in ART in order to accommodate a TB preventive therapy regimen, can the patient be supported to maintain good adherence with a switch? How complicated is a switch? A regimen of Descovy dolutegravir switching to Truvada dolutegravir is pretty invisible to the patient, and that's pretty straightforward. So that could be considered an easy switch. But if you're switching from a 1-pill Biktarvy to a 2-pill regimen, that could potentially cause some problems. And the 2-week tail of needing to keep dolutegravir at double dose can be confusing for patients as they're finishing their TPT. If patients are highly treatment experienced or they're not suppressed, they may have very limited ART options. And so the TB preventive therapy option may need to be selected to keep the ART optimized. So balancing priorities for patients. Finally, considerations for choosing a TPT regimen. There is a national shortage of rifapentine, so that really limits the 3 HP and 1 HP options for our patients. As of today, the FDA still lists it as a national shortage. Thinking about lab monitoring, we generally recommend getting a CMP at baseline, considering periodic LFTs, but not required. But certainly in the presence of any new emergent GI or liver symptoms, liver enzymes should be checked. Adherence support should be in conversation with the patient. Daily observed or directly observed therapy or videos observed therapy can be helpful with a weekly regimen like 3 HP, but it is not mandatory. And I give 3 HP all the time when I can get rifapentine to people without daily directly observed therapy. Finally, I just want to highlight the resources of the UW ID eConsult. We are always happy to provide recommendations about TB preventive therapy, and that's a great resource for folks within the UW system. There's an EPIC order for eConsult infectious diseases. We love talking about interpreting quantiferon results and making recommendations for choosing a TPT regimen. And the National HIV curriculum also has a really nice section on TB preventive therapy and latent TB in people living with HIV that I also recommend. And I will pass it off to Lara.
Thank you. Okay, can everyone see my screen?
Yes.
Okay. All right, so switching gears, I'm going to talk a little bit about the treatment of TB disease and HIV. I have no conflicts of interest to disclose. And so I'm going to go through a little bit about standard drug-sensitive TB treatments. I'm not going to talk at all during this talk about resistant TB, which gets a lot more complicated. A little bit about the evidence for treatment shortening and simplification in people without HIV. The challenges of treating people with TB who are living with HIV, and if there is any evidence for shortening treatments in people with HIV, and if we have time, I will talk a little bit about timing of starting TB treatment in folks with HIV. So this kind of general review of standard TB treatments. Most of you are familiar with the 6 months of daily treatment In the United States, we call it RIPE, but in Europe, it is often referred to as HRZE, where you get 4 drugs for the first 2 months, which is then simplified after the intensive phase to a maintenance phase with 2 drugs for an additional 4 months of therapy. As similar to latent TB treatment, TB disease has even more pills. There are some fixed dose combinations which may help, but you often can't use them in HIV, and it is also not recommended to use the less frequent dosing options, in that people without HIV often can simplify their regimen, especially in the maintenance phase, by going down to either 2 or 3 times per week dosing, but daily dosing is still recommended throughout the course of treatment for folks with HIV. It is a relatively long treatment, although ironically, we call the 6-month regimen of RIPE short course of treatment. And it requires excellent daily adherence. And unfortunately, similar to the old days in HIV before INSTIs came around, incomplete and poor adherence really leads to the emergence of resistance. And therefore, it's often recommended that people have directly observed therapy, which requires a fairly resource-intense infrastructure. There is potential for toxicity, which increases with duration, and so 6 months is a pretty long time. As already was discussed about the drug interactions, particularly with the rifamycin, and then the addition of the risk for immune reconstitution when treating HIV and TB together. So in folks without HIV, polling question, a 35-year-old immunocompetent male is diagnosed with TB based on positive smears and typical changes on chest X-ray. The TB is sensitive to INH and rifampin by PCR, and eventually the cultures are positive for tuberculosis. Which of the following regimens is not a possible treatment option? So 1 is rifampin INH, ethambutol and pyrazinamide for 2 months, followed by 4 months of rif and INH. Then the same regimen, except shortening to a full course of 4 months. Rifapentine, INH, moxifloxacin, and pyrazinamide for 2 months, followed by 2 months dropping the pyrazinamide, or lastly, 2 months of bedaquiline, linezolid, INH, pyrazinamide. So answers are still coming in. And we will go ahead and end the poll and share the results. So the majority of people chose 2. It's not an option, which we'll talk about. So that is a correct answer. It's a little bit of a trick question because answer 4 is relatively new. It's not really approved yet, but there is data showing that it might be a possible option. So let's go through some of these regimens. So there was studies back in the early 2010s that did show that for people who are immunocompetent, who have smear negative and culture negative pulmonary disease only, can potentially get away with doing a 4-month regimen based on the fact that they have posobacillary disease. But with this regimen, you have to confirm that folks have clinical and radiographic response at the end of the intensive phase. Otherwise, the treatment should be extended for the full 6 months of therapy. And so this obviously is a very limited subpopulation of folks who have posobacillary disease and have negative smears and negative cultures, but is not a regimen that can be used in folks with HIV. There also have been multiple studies to show, so rifampin really is kind of the crux of TB treatment. in that it sterilizes the lesions and kind of gives persistence to the cure. And the purpose of ethambutol in the RIPE regimen really is just to kind of preserve rifampin, particularly if there is underlying INH resistance. So as soon as you are able to exclude INH resistance, the ethambutol can be dropped. And that used to take quite a while based on it takes a while for TB to grow out of culture. But now that we have PCR testing, often we can determine fairly quickly whether somebody has underlying INH or rifampin resistance. And as soon as those results are back, you can see by the graph that the results really were the same, whether ethambutol was continued until the 8-week mark or dropped early on. There's been several studies that attempted to shorten therapy by switching out ethambutol for a fluoroquinolone, because fluoroquinolones have been shown to shorten the time to culture conversion. And despite that, the studies have really shown that fluoroquinolones alone is insufficient to be able to shorten therapy to 4 months. And the WHO stated in their 2017 guidelines that basically it is not to be used to use a 4-month fluoroquinolone regimen that just substitutes ethambutol with either moxi or levocin. However, then more recently, there was a study looking at a 4-month regimen, including rifapentine rather than rifampin, both with and without moxifloxacin. It was a pretty large study that enrolled over 2,500 patients and involved 13 countries. It was a randomized open label phase 3 non-inferiority trial that was sponsored by CDC's Tuberculosis Trials Consortium in collaboration with NIH's AIDS Clinical Trials Group. And so, as you can see in the trial design, the control group was basically standard 6-month therapy, which what we would refer to as RIPE, compared to substituting rifampin with rifapentine. It was a high dose rifapentine of 1,200 milligrams a day, versus a third option that used rifapentine, but used moxifloxacin instead of ethambutol. And the primary endpoint here was TB survival at 12 months after randomization, although there's now data going out to 18 months that shows very similar results. And they used a non-inferiority margin of 6.6%. And basically what they found was that the 4-month high-dose rifapentine and moxi regimen was non-inferior to standard daily 6-month regimen, but that the rifapentine alone regimen was not. And so you can see in the bar graph, relatively equal whether you looked at microbiologically eligible population, which were folks that were smear positive, versus the accessible population, which are folks that showed up to their 12-month follow-up visit. And in the line graph, you can see that really the benefit of the rifapentine, moxi, and control group regimen is that they had less relapses after about later after therapy was completed. It is true that the rifapentine moxi regimen had more grade 3 adverse events than the rifapentine only group, but it was comparable to the control and therefore considered an acceptable level of side effects, given it is similar to what we're currently using. And so in conclusion, a 4-month regimen containing rifapentine and moxifloxacin was non-inferior in efficacy and similar in safety to the standard 6-month regimen that we use for treatment of TB. And as a result of this study, the WHO guideline in 2021 basically conditionally recommended this regimen as a possible treatment regimen for folks without HIV. Then there were two studies that were long awaited for the results that were presented this past week at CROI. These were two studies that were originally started enrolling patients back in 2018. The first study was called Simplicity TB, that was run by the TB Alliance. And there actually were two parts of this study. We're only going to talk about the part in relation to folks that had drug-sensitive TB. But there was another arm that included folks with drug-resistant TB. And as you can see, they enrolled 300 participants, and they compared 6 months of HRZE or RIPE to a new 4-month regimen that included bedaquiline, protomanid, moxifloxacin, and pyrazinamide. It was a fairly large study that included 10 countries. And they did enroll people with HIV if they had a CD4 cell count greater than 100 and were already on antiretroviral therapy. But unfortunately, although participants in this study showed that they were 3 times more likely to culture convert by week 8 if they were on the bedaquiline regimen, it did not meet non-inferiority, and mainly it was because there was difficulty with adherence in folks on the experimental arm because of the degree of side effects. And so it was felt that the control arm had better outcomes. And the other study is a complicated study that was presented at TROI, which is the Truncate TB study. Which was a study of 2-month regimens using novel combinations to augment treatment effectiveness for drug-sensitive TB. So basically what they did here is they did, the control group was the typical 6 months of RIPE, and they enrolled 675 participants from 18 sites in 5 countries. The experimental group had 4 arms, and really the focus here was on strategy rather than the actual regimen, where they did 8 weeks of one of these 4 regimens with the idea that if symptoms persisted or folks remained smear positive, that the regimen could be extended to 12 weeks. They then were reassessed again at 12 weeks, and the regimen could either be extended to 24 weeks, or at that point, they can be switched over to a standard regimen. Their plan from the beginning was to drop 2 of the 4 experimental groups based on early stopping rules in order to maintain statistical power, but none of the groups actually met the standards of stopping. And so they wound up just dropping 2 groups based on logistical criteria, mainly on pill burden, but also on regulatory concerns of the drugs. And so they dropped both the rifapentine and the clofazimine groups, and only moved forward with the rifampin linezolid group and the bedaquiline linezolid group. And so 660 participants wound up following through to 96 weeks. Their primary outcome was a composite of death, ongoing treatment, or active disease at week 96. And they used a non-inferiority margin of 12%. And based on their primary outcome events, you can see that they had poor outcomes in about 3.9% of the control group, 11.4% of the rifampin linezolid group, and 5.8% of the bedaquiline linezolid group. And so based on those results, it was felt that rifampin linezolid did not meet the non-inferiority criteria, where the bedaquiline linezolid group did. Based on that, if you took a closer look at the bedaquiline linezolid group, 85.7% received only 8 weeks of therapy. But keep in mind that going beyond 8 weeks of therapy was not considered a treatment failure, since it was part of the strategy design. So even with the 15% that went beyond 8 weeks, the mean length of treatment in the bedaquiline group was 84.8 days versus a standard regimen of 180.2 days. So it cut treatment length overall in about half. There were 2 cases of acquired drug resistance in the bedaquiline group, and this was a concern from the beginning because bedaquiline has a really, really long half-life. And so essentially, once treatment ended, you basically by default are on bedaquiline monotherapy for several months after therapy. But only 2 cases of acquired drug resistance was considered to be acceptably low. But there clearly needs to be more and longer studies to see if this is a significant difference or not. The other concern is that bedaquiline still has a black box warning based on initial studies that was related to higher all-cause mortality and QTc prolongation. But with baseline EKGs in this study, there was limited toxicity. Obviously, we're all familiar with the long-term toxicity of linezolid with cytopenias. But again, with only 2 months of therapy, the majority of people did not have significant toxicity during this study. This is really preliminary results, though, and so as of right now, this is not yet an approved regimen. So what about shortening TB treatment in folks living with HIV? So another polling question. A 25-year-old female with HIV is diagnosed with drug-susceptible TB. She has been on bictegravir, TAF, and FTC, otherwise known as Biktarvy, and fully suppressed. What is a possible treatment option? And so Adrienne went through a lot of the drug-drug interactions. And so hopefully you may know the answer to this. You would start a standard regimen and continue ART, start a standard regimen and switch to BID dolutegravir, TAF, and FTC, start a standard regimen and switch to BID dolutegravir, TDF, and FTC, start INH, rifapentine, moxifloxacin, and PZA for 4 months, and switch to BID dolutegravir, TDF, and FTC, or start a standard regimen and extend it to 9 months. So I will end poll there. It looks like most of the people chose number 3, which I agree would probably be the best choice for this particular patient. And we will talk about why. All right. So we already mentioned the issues with rifampin lowering concentrations of many ART meds, and as was already stated, Atripla or an efavirenz-based regimen is really the only one with no interactions, but really is no longer first line. Dolutegravir often needs to be BID, and TAF can't be given with rifampin, and we have to revert back to TDF. Even more so than with latent disease, obviously, there's a lot more pills in relation to the TB regimen. And then when you combine that with the more pills with HIV regimens that are often necessary, it can definitely lead to ART failure. We definitely need more PK studies to ensure that ART remains effective, particularly studies with bictegravir. And that if we can get shorter treatments, there would be less interaction concerns, but the 4-month treatment for culture negative non-cavitary pulmonary TB is not an option due to a greater risk for failures in people with HIV. So what do we have? So that same study that looked at rifapentine with and without moxifloxacin did enroll folks living with HIV, and they finally published the sub-analysis based off of that population. So about 8% of the overall study population had HIV, which was a total of 214 participants. And as you can see, HIV was used as a randomization standard across all 3 arms of the study. And in the end, they had about 50 to 60 individuals who were accessible at the 12-month mark to determine whether or not the rifapentine regimens were a reasonable option. However, keep in mind, one, they only included folks with a CD4 count greater than 100. And two, they only included folks on an efavirenz-based regimen, either at the start or folks that were going to be starting an efavirenz-based regimen within 8 weeks of starting their TB treatment. And so they did find, similar to folks without HIV, that the rifapentine moxifloxacin regimen, but not the rifapentine alone regimen, did meet their non-inferiority margin of 6.6%. But again, only for people with higher CD4 counts on an efavirenz-based regimen. Based on this analysis, the CDC did add this regimen as a possible regimen for folks living with HIV, with the caveats that I already mentioned. The Truncate TB trial that looked at all of the different combinations of 2-month options for folks with HIV, options for folks with drug-susceptible TB, initially excluded higher risk patients, including those living with HIV, but they actually later changed their entry criteria to include this population. Unfortunately, however, despite changing their entry criteria, they did not wind up enrolling anyone with HIV. And so currently we have no data looking at the 2-month options in folks with HIV. So in summary, the current available options for TB for folks with HIV is either still the standard 6-month regimen, or the 4-month regimen that uses rifapentine and moxifloxacin, but only for folks with higher CD4 cell counts and only for folks currently on an efavirenz-based regimen. Although there are current PK studies looking at dolutegravir levels in combination with this regimen. So lastly, and very quickly, I'm just going to talk about the changes and updates in recommendations of when to start HIV treatment in folks on TB treatments. So obviously, it's kind of the usual balance in that starting ART has a higher risk of immune reconstitution, especially in folks with lower CD4 counts, lots of drug interactions, lots of toxicities, and pill burden. But we also balance that with the idea that not starting ART leads to persistent immunosuppression, which is of particular risk to folks with low CD4 counts, prolonged risk of non-TB comorbidities and mortalities that we have with people living with HIV, and lower rates of TB cure with TB meds alone. And so there's been several landmark trials, and in summary, I will just say that earlier is better. A lot of the initial studies showed that earlier is particularly better in folks with really low CD4 counts, and of no surprise, you have a higher incidence of IRIS if you start ART early, but that was counterbalanced by the lower mortality rates. And so the WHO 2017 guideline said that TB treatment should be initiated first, followed by ART as soon as possible within the first 8 weeks. But if folks have a CD4 count less than 50, it really should be started within the first 2 weeks. But to kind of counter the risk of IRIS, some expert opinion is to consider prophylactic low-dose prednisone for 4 weeks to kind of reduce the risk of IRIS. But newer guidance from WHO in 2021, both for TB and for HIV, really says that ART should be started as soon as possible, ideally within 2 weeks, regardless of CD4 count among folks living with HIV. The one main exception to that, of course, is TB meningitis, where ART should be delayed for the first 8 weeks, regardless of CD4 count, just because of the risk of IRIS in that setting. And I will end with some future directions, and then we can take questions. So Is less than 4 months of treatment possible? I think we don't know. Unfortunately, the Truncate TB study was unable to enroll folks living with HIV, so it remains an unanswered question. There's with some of the ART regimens, whether they can be overcome by therapeutic drug monitoring, I think right now it is a little bit less clear on how to use that. It would be really great to be able to combine TB regimens with bictegravir, which is the first-line therapy now for HIV. And as I said, ACTG 5406 is really looking at PK levels of dolutegravir in combination with the rifapentine moxifloxacin 4-month regimen. And then I think the HIV world is changing with all of the new injectables, both for ART and PrEP. And at least as of right now, none of the TB studies really address those drugs in combination with TB treatments. And I just want to acknowledge that Mountain West AETC is supported by HRSA grants. And I also want to acknowledge Adrienne and to thank her for sharing some of her TB slides. And I think at this point, I will stop sharing my screen and we can take questions.
Thank you both so much for a fantastic talk. I think Adrienne's already answered one of the questions, but if people haven't seen that yet, it was a question about what Lara just alluded to about long-acting injectable therapy. And as of right now, as she mentioned, it's contraindicated. And Adrienne, if you wanted to talk about that study that you put in there.
Sure. So Sylvia had asked what the recommendations or evidence was for using rifamycin, either TB treatment or TB preventive therapy with long-acting cabotegravir, either in Cabenuva form for treatment or what we know about Cab for PrEP. And there haven't been studies of people with HIV getting Cabenuva treatment who have also been given rifamycin-based TPT, but there was one study done looking at oral cabotegravir given with rifamycin-based TB preventive therapy, and it found that it dropped the levels of cabotegravir below therapeutic levels. So current recommendations are to not give rifapentine with long-acting cabotegravir. What does that mean? If you have a patient who's on Cabenuva and they develop active TB, I think that would definitely be a consult question for some of the probably TB clinic, because so I think for TB preventive therapy, it's pretty easy to say, don't pick a rifamycin-based TB preventive therapy. You have other options given isoniazid only TB preventive therapy regimen. TB treatment, there's probably going to be some need to potentially modify or supplement the ART that they're getting if they're getting long-acting. And yeah, so Bob was asking if there was a CROI abstract suggesting that dolutegravir given daily with rifampin was okay. Yes, so there was a study from South Africa looking at dolutegravir ART with unsupplemented dolutegravir. So TLD, the dolutegravir, tenofovir, TDF, and lamivudine ART regimen was given with daily rifampin, and the data was suggestive that it was okay that people maintained therapeutic levels of dolutegravir in that study, so that they were not. It was a phase 2 study. It was relatively small. They were not confident to say that we can fully move forward without adjusting dolutegravir dosing to BID with rifamycins, but it was certainly encouraging that there may be a potential to study that further, and it would certainly simplify dosing with both TB prevention and really critically with TB treatment. Adding a single dose of dolutegravir to a fixed dose combination is really complicated in a programmatic setting and confusing for patients. So I think keep an eye on that space, but at this point, probably continue with supplementing dolutegravir with BID dosing during a course of TB treatment, or daily rifapentine or daily rifamycin TB preventive therapy. And then we have another question. Do you think 4 months of a bedaquiline linezolid therapy is a good idea given some resistance happened? I'm going to let Lara take that. I will also weigh in. I'm not a huge fan.
Yeah, I mean, I think time will tell, and it certainly is a concern, and I think there's reason for it to be a concern. The other reassuring thing in that study, though, is even so there were 2 resistance. One of them, the person had baseline underlying INH resistance at the start of the study. In addition, the person had missed, I think it was 12 days of treatment during the course of therapy. But the other patient that developed bedaquiline resistance had good compliance and did not have baseline resistance. And so I think that one is a little bit more concerning. Both of the patients, though, were able to be switched over to standard therapy and still reach a cure. And so I will switch it to Adrienne on further comments.
I think that sort of the numbers from that study are too small to make any strong recommendations. I think the evidence from that study overall doesn't say to me that we're at the point where we can start prescribing 4-month regimens, which are also complex. I think it's, I don't know, to my mind, it's very suggestive of the potential to shorten treatment further. And I think there are certain patients who both need a shorter regimen because of long-term adherence concerns, and would benefit and do well without the resistance that was seen. And another aspect of Dr. Payton's talk was suggesting that there are biomarkers that can predict who is going to succeed and who is not going to succeed with the shorter course treatment. So I think there's good room to anticipate the possibility of shorter course treatment with the 2-month. Sorry, yeah, not the 4 months, the 2-month. But I think we're still in the more research is needed stage.
I just had one question about the linezolid intolerance over that period of time, because in the BPAL studies, people could not tolerate the BID linezolid, and most of them ended up on just daily linezolid. So in this study, did most people end up going on to staying on the BID linezolid?
I would have to double check, Shreesha,
Okay.
but I'm pretty sure it was daily linezolid.
Daily linezolid, okay.
But I would have to double check that one. And I just to echo Adrienne, I think the most exciting thing, right, is that we have been relying on a 6-month regimen for like 40 years. And so these are like the first studies that are showing that potentially a 4-month or even possibly a 2-month regimen may be adequate for many people, but not everyone.
Well, great. It looks like there aren't any other questions, but you know how to get a hold of Dr. Strick and Dr. Shapiro if you have any other follow-ups. Thank you both so much for these wonderful comprehensive talks and updates and hot off the press information. So thank you so much.
Thank you.